Welcome to session 2A, I think, on reactions. My name is Paul Feim. I've been asked to chair this session, and Dr. Lena Feibig, who's co-chair, will be collecting questions that accumulate on the chat. I've been told to just go over the housekeeping rules. We have 4 presentations in our session, 2 longer ones, 8-minute presentations, and 2 shorter ones. I think in the interest of time and everyone's opportunity, I will be a bit severe on time. Please keep within time. We will have time for questions after each presentation and then towards the end of the session. And please put any questions in the chat box as we go along. So I think we can start with our first presentation, which will be given by Dr. Marlous Grijsen from Oxford University in the UK. And it's entitled Engaging with Leprosy-Endemic Communities in Papua, Indonesia, to Enhance Case Finding, Recruitment, and Retention in the MetLep Trial. Dr. Grijsen, over to you.
Thank you, Paul, and thank you for the introduction and for giving this opportunity to present our work. And on behalf of the MetLep study team, I will present a sub-study that was performed in preparation of the MetLep trial. In this study, we explored the perceptions and the knowledge on leprosy in leprosy-endemic communities in Papua, Indonesia. I would first like to acknowledge Professor Hadianto Subono from Gadjah Mada University and Hannah Krismawati from Litbangkes, Papua, who have been instrumental in this project. Next slide, please. Yeah. Before going into detail, I would like to briefly discuss the MetLep trial. This trial will evaluate the efficacy and tolerability of adjunctive metformin in multibacillary leprosy to mitigate leprosy reactions and prevent its associated disabilities. Patients with newly diagnosed multibacillary leprosy will be randomized to either metformin or placebo for 24 weeks in addition to the standard of care multi-drug therapy. The total study follow-up will be 48 weeks. We aim to enroll 166 patients. Due to COVID, the study has encountered some delay. Recruitment is planned to start in the following months. Next slide, please. So for the remaining of this talk, I will focus on the sub-study that we recently performed. Leprosy-related stigma is a major barrier to accessing health care and to trial recruitment. And has a negative impact on health-seeking behavior, prolonging the risk of transmission, undermining treatment, and increasing the risk of developing disabilities, which again increases stigmatization. For interventions to be effective, it is important they are culture-specific and address local beliefs and knowledge gaps. So the objectives of our study were to improve our understanding of social health aspects of leprosy in Papua, to involve patients and public in designing leprosy research and care to improve acceptability, and to enhance case-finding, recruitment, and retention in the MetLep trial. Next slide, please. So we performed a community-based cross-sectional study in Jayapura, which is the capital of Papua in eastern Indonesia. The prevalence of leprosy in this area in 2019 was 4.74 per 10,000 population. We used the previously developed and validated NLR perception study toolkit on leprosy. Knowledge and stigma were assessed using the CUP questionnaire, the AMIC community stigma scale, and the social distance scale. Participants aged 18 years and above were randomly selected from 3 different study sites in Jayapura. The toolkit was used among 4 different participant groups. Persons affected by leprosy, also referred to as PAL, their close contacts, community members, and healthcare workers. Semi-structured interviews and focus group discussions were conducted among a purposely selected subset of participants, but this data will not be discussed here. The association of the various parameters with knowledge and stigma scores was examined using univariable and multivariable linear regression analysis. Next slide, please. So a total of 409 participants were included in this study. 74 were PAL, 126 close contacts, 158 community members, which could be any person living in the same neighborhood or village, and 51 healthcare workers. 4 of the healthcare workers had specific leprosy responsibilities. PAL were administered the CAP questionnaire only, and the other 3 groups were administered all 3 questionnaires. Next slide, please. The median age was of all participants was 38 years old. 55% were female, and the majority was Christian. And more than half had completed secondary education. Over 90% of the healthcare workers had completed tertiary education. Half of the participants had a relationship with a PAL. On average, PAL were diagnosed with leprosy 22 months earlier to participation in this study. Half of them were diagnosed with multiple ciliary leprosy, and 16% had visible disabilities. Next slide, please. So this table shows the mean scores of the 3 different questionnaires for each participant group. The CAP has a score from 0 to 9, a higher score signifying better knowledge, and the AMIC and the social distance scale have a score from 0 to 30 and 0 to 21 respectively, a higher score indicating a higher level of stigma. So the average knowledge score for all participants was 4.5. Healthcare workers had the highest knowledge, and the community members the lowest knowledge. 1/3 of all participants had a poor knowledge, meaning a score of 3 or less. The lowest scores for knowledge were related to questions regarding cause, mode of transmission, and early symptoms of leprosy. Stigma scores were highest among the community members. For example, community members perceive that PAL have a low willingness to disclose their leprosy status, that leprosy causes shame and problems for the family, and that PAL have difficulties finding a job. Questions that indicated the most negative attitudes were towards marriage with PAL and PAL as a caretaker of your children. Next slide, please. Even though the numbers were very small, healthcare workers involved in leprosy care had a better knowledge compared to their colleagues who were not involved in leprosy care. Regardless of being involved in healthcare, there is still substantial stigma towards leprosy among healthcare workers. Next slide, please. The multivariate analysis showed that participants who had a close relationship with a PAL had a significant better knowledge, lower levels of perceived stigma, and a more positive attitude towards leprosy. Next slide, please. So this study shows poor knowledge regarding leprosy, particularly among close contacts and community members. Healthcare workers involved in leprosy care had a better knowledge than their colleagues. In addition, there was a high level of perceived stigma on leprosy. And having a close relationship with a PAL is favorable for knowledge and perceived stigma. The outcomes of this study have been adopted to establish a community advisory board and to design public engagement activities to improve the community, the literacy in the community, to reduce its associated stigma, and improve the acceptability of the MetLep trial. Next slide, please. So I would like to thank all the investigators involved in this trial and our funders, the LRI, the Turing Foundation, OCRU, and the Wellcome Trust, who have supported the funding of this sub-study. I also want to thank Anne Noordende and Wim van Brakel for introducing us with this perception toolkit. And with that, I would like to hand over back to the chair.
Thank you very much, Marlous, and thank you for keeping to time. An interesting presentation there. we have a few minutes for questions. I wonder if any have come up. Lena?
No questions have come up in the chat, but it's not too late yet. In the meantime, I'm happy to ask a question.
Please.
Thanks so much for the presentation. I'm curious to hear now with these interesting results, what will the results be used for? Are there any plans?
Well, like I mentioned in the last slide, is the most important. The initial setup of this study was to establish a community advisory board to help us support and set up the trial. So to review our informed consent and patient information sheet, to get input how to best implement, set up this trial in the area, recruit participants, just to get them involved and to get them the community aware of this study which will be ongoing. And in addition, also to develop public engagement activities to improve the literacy on leprosy, because we found that the knowledge on leprosy is relatively low, particularly in community members. So we have actually already, for the World Leprosy Day, we have set up a photo voice project, which was supported by Sasakawa Leprosy Initiative. And we had a photo exhibition, which was done by leprosy patients to create awareness on leprosy. So that was actually a very successful program already, and we did that last January. So that this is like a starting point.
I might ask a question. I was interested to see that your study population is overwhelmingly Christian. I'm not that familiar with Indonesia, but it's an overwhelmingly Muslim population. And what does this say? Is this a particular socio-ethnic group that you're studying? Could you comment on this? And as you mentioned, the issues of stigma are culture related. And so will your findings be applicable more broadly within Indonesia?
Yeah, so thank you for that question. It's a very good question. I think so. First of all, Indonesia is, I don't know if you've ever traveled to Indonesia, but it's a huge country and it stretches. If you put it on the map of Europe and further, the tip of Sumatra will be in London, and then Papua, which is the complete eastern part of Indonesia, goes all the way to Afghanistan. So just to give you an idea how huge this country is. So there are a lot of diversities. And the main island is Java, which is Muslim, but the eastern part of Indonesia, which is also the poorest part, Papua being one of the poorest, or being the poorest province, is mostly Christian. So that's why you find that this is a Christian population. Also, if you look at ethnicity, Papuan people are very different from Javanese or Sumatran. And I mean, Indonesia is a very diverse country and community. So I think you are right that what we find here may not be maybe very different than if you look in a Javanese population.
Is this one of the highest prevalence regions in Indonesia?
Yes.
It is.
Yeah, it is. Yeah, it's one of the poorest areas, and one of the highest, Eastern Indonesia in general.
So we turn to our second talk, which will be given by Dr. Barbara de Barros from the London School of Hygiene and Tropical Medicine. And its title is ENLIST MTX, 2 randomized controlled trials of methotrexate in erythema, nodosum, leprosum. Over to you, Barbara.
Thank you, Professor Paul Fine. Thank you. So, the presentation is there. So my name is Barbara. I'm an infectious disease doctor from Brazil, but I live in London now, and I work at the London School of Hygiene and Tropical Medicine with Dr. Steve Walker. And I'm presenting the methotrexate and the prednisolone study in ENL by the ENLIST group. Next, please. So the ENLIST group is a consortium created to study ENL. We are 9 centers in 8 different countries, and now we are focusing on the steroid-sparing agents and alternatives to thalidomide. There is a gap in our knowledge in this area. Next slide, please. So we are trying to fill this gap and with the MAPS. So the MAPS is the methotrexate and prednisolone study in ENL. It is a multi-center, double-blind, randomized clinical trial. So methotrexate has been used in ENL patients before. It is cheap, and clinicians and nephrologists are familiarized with it. It's widely used in other skin diseases. So we are aiming to recruit 460 patients, 142 acute ENL patients, and 274 chronic and recurrent ENL patients. So participants will be recruited from 6 different centers in Bangladesh, Ethiopia, Indonesia, India, and Nepal. So ENL patients will be randomly allocated to receive either methotrexate and prednisolone or placebo and prednisolone. Participants will be followed for 6 weeks, and at the statistical analysis will be stratified in acute and recurrent or chronic ENL. So we are working with standardized classification definitions, and we will use quality of life questionnaires as patient-reported outcome measures. Next, please. So we will recruit among ENL patients, and after the eligibility assessment and informed consent, participants will be randomized to receive either methotrexate, 15 or 20 milligrams weekly, depending on their weight, for 48 weeks, reducing to 0 over 4 weeks, and prednisolone daily, 40 milligrams daily, reducing to 0 over 20 weeks. Patients in the control arm will receive a dummy tablet for 48 weeks, plus prednisolone, same regimen as the intervention group. Next slide, please. So by February 2020, we had adequate approvals in all centers, budget agreements, contracts. We secured methotrexate donation by the CIPLA Foundation. We found a company in India to produce the placebo pack and ship the study medication. We had all this in place, plus the data collection instruments were ready. We are using RADCAP. The ENLIST centers were testing our ENL severity scale, which will be used as an outcome measure. All the standard operational procedures have been written and reviewed, and the clinical trial was registered at the clinicaltrials.gov. So we have also a data safe monitoring board committee established, but then everything was put on hold. Next, please. So despite that, we continue to work on this study. We published the study protocol article at the BMJ. Next, please. We use this time to assess the impact of the pandemic in leprosy service. We decided to do a survey asking how the pandemic impacted leprosy referral centers' practice and their patients. We use RADCAP to do an online survey to send to healthcare professionals in leprosy referral centers. We obtain responses from centers in Bangladesh, Brazil, DRC, Ethiopia, India, Indonesia, Nigeria, and Sri Lanka. So the results of this survey was published in the Royal Society of Tropical Medicine and Hygiene journal, Transactions, and we found that social measures like travel restriction and elective health service restrictions reduced patient access to leprosy referral centers. The restrictions and delay to access this service may lead to increased risk of permanent damage and disability. Next, please. So alongside to that on maps, we had to recalculate the budget and monitor closely the COVID-19 situation in each country. I'm monitoring the literature on the added risk of severe infection of COVID-19 in immune-suppressed patients, especially individuals who are chronic users of corticosteroids and methotrexate, people with leprosy. We were reassured that methotrexate seems to be safe in this context. We developed COVID-19 protocol for the trial participants. We developed also a contingency plan foreseeing COVID-19 pandemic lasting for the next year. And we are constantly working with ENLIST centers to have a minimal interruption to this study as possible. We further develop online material, which will be available publicly as examples for colleagues to access. Next, please. So during the literature searching, I came across this interesting case from India, a severe ENL patient treated with methotrexate and high doses of corticosteroids. He was tested positive for COVID-19 and developed only fever. No oxygen supplementation was required. This was before vaccination was available, and throughout he continued to receive corticosteroids and methotrexate. This account was very reassuring to us, and there is no indication in the literature so far that leprosy patients have higher risk to develop severe COVID. Next, please. So we also updated the ENLIST website, and I'm working on the new maps section on the site to host all the study material like protocols, SOPs, training materials, and this will be updated regularly and open to public access. Next, please. This is the current status. So placebo is being produced, and then with methotrexate, we're packed and labeled in bespoke design labels and packed and shipped to each center. We will have in-person training hopefully starting in May, and recruitment of participants will start soon after. We will test the prednisolone to ensure the quality across all centers, and we have a scheduled meeting in November before the Leprosy International Congress in Hyderabad. Next, please. So I'd like to acknowledge all members of our group and thank our funders. Thank you for your time, and I'm happy to answer any question.
Thank you very much, Dr. de Barros, and for keeping to time. We have 3 minutes for questions on this presentation at this point.
So in the meantime, I have received the questions for presenter number 1, but I haven't received questions for presenter number 2 yet. If anyone sees any, please tell me now.
Okay. In your title, you refer to this as 2 trials.
Yeah, they are 2 trials, but we are keeping as, like, in my mind is 1, because
well, maybe you clarify this, please.
Yes, because we are doing the same procedures for everybody. Everybody will be tested at the same time. Will be follow up for 60 weeks, and then in the analysis, we're gonna divide it into acute ENL and then chronic and recurrent ENL. But everything that since like the recruitment and the analysis, everything will be the same.
Okay. So in that sense, it's 2 trials, one for acute ENL and one for
chronic. Yeah, exactly. But I'm doing both at the same time in the same manner.
So now we have a question from Dr. Jessica Fairley. I assume that thalidomide is not available in the country sites for the trials.
Yeah, that's the idea. That most of the countries that we are working, thalidomide is not available. So that's why we are using this scheme of methotrexate and prednisolone. But in the countries that they are, there is not a exclusion criteria. If the patient is using thalidomide, we can assess and see if they can enter the study.
But I now go to our third presentation. It's a shorter presentation, just 3 minutes, and it will be given by Dr. Julien Ake from Project Hope, Effect Hope in Canada, entitled Exploring Strategies and Identifying Effective Mechanisms to Mobilize Persons Disabled as a Result of Neglected Tropical Diseases to Influence Policy and Programs to Ensure Person-Centered Approach for Affected Persons in Cote d'Ivoire. Over to you, Dr. Ake.
Thank you very much. It is my pleasure to present this study, which is at its very beginning stage, and it is run in Cote d'Ivoire, West Africa. As it is mentioned there, the title is Exploring Strategies and Identifying Effective Mechanisms to Mobilize Persons Disabled by NTD to Influence Policies and Programs. Next slide, please. Next slide, please. Okay, as background, the project is going to happen in Cote d'Ivoire, where we have a significant proportion of people affected by NTD and living with permanent disability. The health system focuses on curative services and cannot manage alone the long-term physical and socioeconomic consequences of a person affected by NTD. This is likely due to the lack of strong coordination mechanism involving several sectors: education, employment, health, and so on. And the result of competing priorities for resources, and also due to the lack of clear demand and influence of persons affected by NTD on agenda setting and resources allocation at the policy level. So the question that this study wanted to answer is, what are the benefits and challenges of different intervention strategies to mobilize people disabled by NTD to influence government policies and programs to improve the access to services? Next slide, please. So the aim of the study is to develop an evidence-based intervention strategy to amplify the input and influence of people disabled by NTD into program and policy that impact their life. It is a two-stage or two phases study. The first phase is the formative phase, which will be run through a mixed method to collect data from people disabled by entities, caregivers, and key informants, in addition to desk review and explore to explore the need and challenges of those people disabled by NTD. In the second stage, which is the intervention phase, we will, based on the finding of the formative phase and through a participatory approach, develop a people disabled by NTD-centered intervention strategy to influence the input and influence program that impact their life. We will then test and validate the intervention strategy. The next slide, please. So, as expected result of this study, we want to come out with a validated intervention strategy and toolkit that can be used and adapted to mobilize underrepresented groups to influence policies and programs that impact their life. Thank you very much for your attention.
Thank you, Dr. Ake, for that. We have 1 minute for questions at this point. Have any come up?
No question has come up yet.
that I might just comment that there's rather complicated issues. Do you have plans for a trial, a proper trial, in order to evaluate these interventions as part of this study? Or is that
Yes.
for subsequent work?
Yes, I mean, the first stage is we are going to conduct, or we are already in the process where we are conducting a baseline study, which will enable us to have all the information related to the needs and the challenges faced by the people disabled by entities. And based on the funding, we will develop a strategy which will be implemented to test how best it works, the advantage and also the challenges related to that. And we'll go back again for another evaluation to see the difference before and after the strategy intervention.
Okay, that's
Now
that's all we have time for here. According to the program, we had just 1 minute for questions, but we will have time at the end. We now come to our fourth presentation, which will be given by Mr. Stephen Boateng on assessing electronic data collection tools, pathways, and HMIS integration for leprosy and LF MMDP data to improve service delivery. Mr. Boateng.
My name is Stephen, and I'm presenting for NLCP Ghana with support from ALM. So one of the main interventions in leprosy case management is mobility management and disability prevention. However, in the course of the treatment, there are some challenges we encounter in collecting epidemiologic data to support disability prevention. Most of the data that is collected within the program is aggregated data and is collected at the beginning and then at the end of treatment. And therefore, there is some missing information. Fortunately, there is an increased availability and use of digital tools that provide opportunities to support data collection and improve MMDP pathways. So this study seeks to explore advantages and disadvantages of these tools and also examine essential data required to implement a comprehensive and integrated MMDP intervention.
We don't seem to have slides showing.
Yes. Yes. So I was explaining the challenges we face in collecting epidemiologic data to provide MMDP services to leprosy patients, and that the increased availability of digital tools gives us the opportunity to support data collection that will give us this, that will improve MMDP pathways. And so that is what we seek to explore in this study, the advantages and disadvantages of the digital tools, and examine the essential data required to implement a comprehensive and integrated MMDP intervention. Next slide. So the study will be conducted in Ghana by the NLCP with support from ALM, and it's divided into three major components. One is an exploratory survey of participants' practical use of digital tools and a literature review of publications. This has been completed. The second is the in-depth study of tool application and ODK tool development, pilot testing and deployment of the tools. This is an ongoing process. And then the third one is an evaluation of the use of data to support MMDP and improve patient outcomes. So on the right is the welcome screen to one of the forms that we are going to deploy. Next slide. So this is the data flowchart that has been developed as part of the study. On the left is the paper-based pathway as exists currently within the program in Ghana. And then on the right is the electronic pathway, which will be introduced by way of this study. Next slide. So our study findings for the literature review. So 7 search strings were used in 3 databases, and this returned 13 relevant literature. On our stakeholder survey, 13 respondents were surveyed, 12 used digital tools for leprosy, 7 for lymphatic filariasis, and 2 for other NTDs. 5 of our partners that were surveyed used ODK, 3 used RedCap, 2 used Kobo Toolbox, and there were a host of others, 8. Then 52 district and regional officers were interviewed via phone call, and some key findings included the availability of data to persons requesting, depending on their functional levels. And then there was also variance in data that was reported at different functional levels for the same data sets. Next slide. Yes, we are very grateful to our funders, LRI, ALM, the Ministry of Health Ghana, and then the Ghana Health Service. Thank you.
Okay, thank you for that. Sorry for the technical problems. Just a minute now for any immediate questions for Mr. Boateng about that presentation before we turn to open discussion period.
So, Paul, so far we haven't received questions in the chat. But I would be curious to hear what, Dr. Boateng, what you're going to do now with the results.
Okay, so the results informed us about the data that we needed to collect. The data is a lot of information that we can collect, but then we needed to get firsthand from the respondents what information they really need to provide that integrated intervention, MMDP intervention. So with this information, it has guided us on what information or what data sets to put in the digital tools, collection forms, and that is what we are deploying now.
Okay, thank you for that. I think we can open the discussion now for questions on any of these 4 presentations. According to the program, we have another 15 minutes until 16:45 Central European Time. So now questions about any of our 4 presentations, and I think some had accumulated on the Q&A. Is that correct, Lena?
Yes, exactly. We have 2 more questions for presentation number 1. And then the first question is from Dr. Idessa Gobina, and it is, do we have standardized and validated knowledge measurement tool which can be applied anywhere for leprosy?
Recently, the NLR has published a toolkit called, I think they call it Perception Study Toolkit. And this is actually for NTD in general, so not only leprosy, but also other NTDs. And this can be used. The idea is that this can be used anywhere in any region, and this has been validated in several countries. I believe in India, in Indonesia, in Brazil, and I'm not fully at least those countries. So yes, this CUP toolkit can be used everywhere. And the idea is, of course, that if because it's standardized, that if people use it in different settings, that it's easier to compare. Because in many studies that have been done in the past on knowledge and stigma, many different CUP questionnaires have been used. So it's very difficult to compare. Some studies are not showing what kind of questions they have been asking. So it's very difficult to compare different regions. But if more studies will use this toolkit, it will be much easier to compare, and which is also good for research and for implementation of advocacy programs and so on.
Professor Willem Faber has asked the first presenter, it appears that participants in general have a high level of education. Do you think that they are representative for the whole population?
I think that's a very good question, and it surprised me as well, because the illiteracy was only 3% of the population, and most people, more than half, had completed secondary school. So that is actually I don't know. I'm not sure. I think I was actually in the beginning. I was wondering whether there's maybe some confusion with the Indonesian schooling system, or I think I'm not sure, to be honest, to the question. Yeah. Because what we also found, and that I didn't mention, but in the multivariable analysis, we also found that certain, higher education, for the AMIC and the SDS, was actually associated with more stigma. So university was actually going to having completed university or secondary school was associated with a higher SDS score. So that actually also surprised me. We did this study very recently, so we haven't actually we analyzed the data for this event, but we haven't actually had the time to dig into this in more detail. I thought it was surprising as well.
Okay, thank you. Other questions out there?
So we do have more questions. We have one question for presenter 3 for Dr. Julien Ake. And the question comes from Dr. Steve Walker, and it is, which entities and how do you define disability?
Thank you very much for the question. For the question related to which entities, the entities we are targeting in Cote d'Ivoire, those who are causing disability, and especially the skin entities. The skin entities first. Beside the skin entities, we have added river blindness, which is also endemic in Cote d'Ivoire, in such a way that we can assess a large categories of disabilities associated to entities. So these are the entities that we have selected. So it is lymphatic filariasis, leprosy, borreliose, yaws, schisto, onco, etc. So we will be working on those entities in 6 different health districts where the highest number of cases are reported. So this is to answer the first question, but can you repeat the second question, please?
The second part was, how did you define disability?
Disability are all those complications associated to entities causing restriction of the potential of people affected by those diseases.
So we have one more question for our last presenter, Dr. Boateng. The question is by Dr. Jos Dekker, and it is, will the data collection tools be used by patients too, or only by health staff? Is there enough skill on digital tools, both with patients and with staff?
Okay, so the tools will be used by healthcare workers, health professionals. So for the patients, no, we are limiting ourselves to only healthcare workers. And for the healthcare workers, there is enough capacity among health workers to use the tool.
Okay, we have a few more minutes if people have other questions that they would like to put to our presenters.
Paul, we have nothing new in the chat box. So long.
Okay, well, if not, we can call this session to a close. Thanks very much to all of our presenters for their for these presentations, and for our participants and those who joined in the discussion. Thank you very much.
Thank
Have
you.
a good afternoon, evening, or whatever it is, or morning for some of you, and we look forward to seeing you tomorrow. Goodbye now.